Dear students, welcome to R.A.T.S, NEET or Next. Students were simply exuberant with their answers and most were stunningly near correct. The first question for discussion is, a 55-year-old female presented to the dermatologist with rashes on her forehead. On history taking, she had recalled a change to a new brand of bindi. The pathology behind is anaphylactic reaction, delayed hypersensitivity, complement-mediated hypersensitivity, and chemical corrosion. Look at the picture over here. There is some reaction that is going on the forehead. Let us see what is behind it. The action is anaphylactic. It is an IgE-mediated allergic response. You people know that there are 4 types of hypersensitivities, of which IgE is associated with type 1. This is an age-old diagram. Please follow. There is a cell called the B cell. This produces the plasma cell. It gets exposed to an allergen called the pollen in this case. Subsequently, you find that the plasma cell it produces leads to the release of the antibodies. The antibodies are again attached to the mast cells. On subsequent re-exposure to the allergen, there is usually a cross-linking of the antigen, that is the allergen, to the subsequent or the adjoining antibodies. This leads to contraction and then degranulation. The degranulation will be producing various substances, including histamine and other chemical mediators. This is the basic pathology of type 1 hypersensitivity. Look at this case. You find that there is a facial edema, puffing of the eyelids, etc. These can be because of vasoactive amines or the arachidonic acid metabolites such as C4, D4, E4. There are a good number of diseases which can cause a type 1 hypersensitivity, including hay fever, penicillin, atopy, bronchial asthma, eczema, contact dermatitis, etc. Question 15. Acanthocytosis in the red blood cells, RBCs, seen in the peripheral blood is due to A-beta lipoproteinemia, renal failure, beta thalassemia, rapid drying. These are some of the references. We shall touch upon them later. But now, what is important for us will be, what are all the morphological abnormalities of the RBCs we can see in the peripheral blood. The answer in this case is A-beta lipoproteinemia. And look at the morphological abnormalities. If this is a normal RBC, a macrocyte, microcyte, elliptocyte, target cell, teardrop cell, sickle cell, acanthocyte. This is what we are bothered about. It has got an amoeba-like extension, blunt extension, acanthocyte, spherocyte without a central pallor, courtesy Labpedia. This is again a wonderful spectrum that has been derived from the net. I would like you people to kindly go through it. Just go through the different morphological abnormalities. I'm not going to read them out again. Later on, each one can be asked as a question. Let us have that in mind. For example, rouleau formation can be there in multiple myeloma. Basophilic stippling can be present in lead poisoning, so on. There are 3 morphologies which are related. One is called, these are what we call the helmet cells, something like hemispherical or helmet-like cells. They are seen in hemolytic anemia, hemolytic uremic syndrome, and dialysis. These are the acanthocytes that we had spoken about just some time back. They occur in malnutrition, liver disease, and A-beta lipoproteinemia. And sometimes on drying, you find just like a cloth, they develop wrinkles all over, which are called crenated RBCs. Courtesy, JT. The next question is, a 32-year-old male was brought to the hospital with complaints of dyspnea on exertion and mild petechial hemorrhages. On examination, mild hepatosplenomegaly was noticed. There was no generalized lymphadenopathy, a negative point. The hemogram is important. The hemoglobin was 6 grams, total count 2,800, platelet 31,000. We can call it a pancytopenia. As a reaction, the reticulocyte count was 5.4%. The bone marrow was hypercellular. The probable diagnosis in this case is hypersplenism. Now, why do I rule out the other things? We shall be seeing. Aplastic anemia means probably there will not be a rise in the reticulocyte. Secondly, bone marrow will not be hypercellular. What is hypersplenism? It can be a primary or a secondary reaction. It can occur in unknown conditions, hence it is primary, or secondary in cases of cirrhosis, malaria, lymphoma, various infections or inflammations, sometimes in tuberculosis also. And a patient presents with a pancytopenia. This can be corrected by means of a splenectomy, and the size of the spleen is mild to moderately enlarged. It is not massively enlarged as in the case of a malaria or a myelofibrosis. And the physician will have to judge the condition. So, splenomegaly and pancytopenia, normal bone marrow, portal hypertension, sequestration of the cells, pancytopenia, splenectomy after assessment. And these are the sources of references. The next question. The most common malignancy induced by asbestos exposure is bronchogenic carcinoma, non-Hodgkin lymphoma, pleural mesothelioma, peritoneal mesothelioma. The reference is given over here. Dear students, be very careful when the questions are very simple. My professor used to say, mesothelioma is the most common tumor in asbestosis. But then bronchogenic carcinoma is 3 times more common in cases of asbestosis when compared to mesothelioma. So obviously the answer is bronchogenic carcinoma. If you people have got any doubts, go and read in between the lines of Robbins. And this is the thought for the day, a very important analysis. The answers are given over here, the subjects that are concerned with it, what are all the references, and who are all the benefactors. As I told you, it will be from the first year to the CRRIs. Finding out the answer is not important. Finding out how important the detractors are more important. Dear students, I hope just like me, you people would have started understanding the sequence of events. I have given you the answer for the day and then the questions for the next day in the same session. I got no problems with any question. In fact, Dixon has said, the greatest fool can ask more questions than the wisest man can answer. A question is given along with the X-ray. A 58-year-old male with cachexia and dyspnea was brought to the medical OP. Routine investigations were asked for. The X-ray showed this picture. The radiology professor diagnosed it as bronchopneumonia, pulmonary metastasis, miliary tuberculosis, multiple infarcts. So this is the question. The next question is, an acole is a microscopic structure seen in malaria, myelofibrosis, multiple myeloma, megaloblastic anemia. Question 20. Target lesion is a term used in hematology, radiodiagnosis, forensic medicine, oncology. Question 20b. A 52-year-old woman was brought to the casualty with acute abdominal pain. The ultrasound picture revealed this. The diagnosis is dash. I'm not giving you any further clue on this. My whole life is waiting for the questions to which I have prepared the answers. Stop. To be continued.